You bend down to pick up a bag of groceries. A jolt shoots down your leg. You freeze. Someone tells you it's a slipped disc, and the first thing you think is that you need to stop moving before you make it worse. But is that actually true? For decades, the advice for a herniated disc was rest, lie flat, avoid bending, wait for it to heal on its own. Today, that advice is largely outdated. Current evidence points somewhere far more surprising. In many cases, the right kind of movement doesn't just protect your spine, it can actively support recovery. So what is really happening inside your back, and how much control do you actually have over it? Let's start with what a disc actually is. Between each of the bones in your spine, called vertebrae, sits a small cushion called an intervertebral disc. Think of it like a jelly donut. It has a tough outer ring, called the annulus fibrosus, and a softer gel-like center, called the nucleus pulposus. These discs absorb shock and allow your spine to bend and twist. A herniation happens when that outer ring develops a crack or weak spot, and some of the gel-like center pushes outward, sometimes pressing on a nearby nerve root. That nerve pressure or irritation from inflammatory chemicals released at the injury site is usually what causes the sharp, shooting pain many people feel down the leg, a symptom often called sciatica when the sciatic nerve is involved. Why does this happen in the first place? Discs weaken gradually through a combination of factors. Age-related changes reduce water content in the disc over time, making it slightly less resilient. Repeated bending and lifting, especially combined with twisting, can gradually stress the outer ring. Prolonged sitting, weak trunk musculature, smoking, and genetics also appear to play a role. Often, a herniation isn't caused by one dramatic moment. That heavy lift just happens to be the final straw after months or years of accumulated load. Here's something that might surprise you. Imaging studies scanning the spines of people with zero back pain regularly find disc herniations they didn't even know they had. A well-known systematic review published in the American Journal of Neuroradiology found that disc bulges and even herniations are common findings in pain-free adults and become more common with age. This doesn't mean your herniation isn't real or isn't contributing to your symptoms. It means that what shows up on a scan doesn't always match how much pain a person feels, and pain itself is influenced by more than just tissue damage alone. So what actually happens during recovery? For most people, herniated discs improve over time without surgery. Research following patients with MRI-confirmed herniations has repeatedly shown that a large proportion of herniated material can shrink or resorb naturally over months as the body's immune cells gradually clear away the displaced material. This is a genuinely encouraging finding, but it doesn't mean the first few weeks are symptom-free or that recovery is purely passive. This is where exercise comes in and where rehabilitation becomes stage-based rather than one-size-fits-all. In the early stage, usually the first 1 to 2 weeks, the goal isn't intense training, it's managing pain, protecting the irritated nerve root, and avoiding prolonged bed rest, which research consistently shows delays recovery compared to staying reasonably active. Clinical guidelines, including those from the American College of Physicians, recommend remaining as active as symptoms allow, using gentle movement like short walks, and avoiding positions that clearly spike leg pain, often deep spinal flexion combined with load.
As irritation calms down, usually somewhere in the following weeks, rehabilitation shifts toward restoring pain-free range of motion and beginning to reintroduce controlled loading. This is where directional preference exercises are often used. For many people with disc-related leg pain, gentle, repeated extension movements, like lying on your stomach and slowly propping up onto your forearms, can help centralize pain, meaning the pain retreats from the leg back toward the lower back. This isn't universal. Some people respond better to flexion-based movement instead, which is why a qualified clinician assessing your individual response matters more than following a fixed protocol from a video. Once acute irritation has settled and centralization has occurred, the middle stage focuses on rebuilding capacity. This means strengthening the muscles that support and stabilize your spine, particularly your deep core, your glutes, and your back extensors, while gradually reintroducing safe spinal movement rather than avoiding it altogether. One foundational exercise here is the bird dog. Start on your hands and knees, spine in a neutral position, not arched, not rounded. Slowly extend one arm forward and the opposite leg backward, keeping your hips level and your core engaged. Hold briefly, then return with control. This trains spinal stability without compressive load, teaching your trunk muscles to resist unwanted movement, which is exactly the quality that protects a healing disc during daily activities. A typical starting prescription is 2 to 3 sets of 6 to 8 repetitions per side, performed slowly with a brief pause at the top. If that's too demanding early on, you can regress it by moving only the arm or only the leg first. Another key exercise is the glute bridge. Lying on your back, knees bent, feet flat on the floor, push through your heels to lift your hips toward the ceiling, squeezing your glutes at the top, then lower with control. This strengthens the glutes and posterior chain, taking mechanical stress off the lower back during everyday movements, like standing up or walking. 2 to 3 sets of 10 to 15 repetitions is a reasonable starting point, progressing toward a single leg version as strength and confidence improve. As symptoms continue to settle and strength returns, the later stage introduces more functional, load-bearing movement. This is where many people hesitate. Surely lifting or bending is what caused this in the first place, but avoiding these movements indefinitely often does more harm than good, leading to deconditioning, fear of movement, and, ironically, a spine less prepared to handle daily demands. The hip hinge pattern, practiced through an exercise like the Romanian deadlift using light dumbbells or a resistance band, teaches you to load your spine safely by bending at the hips rather than rounding through the lower back. Feet hip-width apart, soft bend in the knees, push your hips backward while keeping your spine in a neutral position, lowering the weight along your legs until you feel a stretch through your hamstrings, then drive your hips forward to return upright. This directly rebuilds confidence and capacity for real-world lifting. Starting with 2 to 3 sets of 8 to 10 repetitions using a light load, focusing entirely on technique before adding weight tends to work well. Throughout every stage, intensity and progression should be guided by your symptom response, not a fixed calendar. A useful general principle from current rehabilitation guidance is that some discomfort during exercise is acceptable as long as it doesn't sharply increase leg symptoms, doesn't linger significantly afterward, and settles within a reasonable window. Pain that spikes, spreads further down the leg, or is accompanied by new numbness, weakness, or changes in bladder or bowel control is different and warrants prompt assessment by a healthcare professional rather than pushing through. Progression typically follows a logical order, from isometric holds to controlled dynamic movement, from body weight to added load, from simple single-plane movement to more complex multi-directional patterns that resemble real-world daily and occupational demands. If a particular exercise consistently increases leg pain despite proper form, that's a signal to regress temporarily, adjust the movement pattern, or modify range of motion, not necessarily to stop moving altogether. It's also worth being clear about what exercise realistically does and doesn't do. Exercise does not reliably put a disc back into place. What it does is reduce nerve irritation over time through movement and positioning, rebuild the strength and control needed to protect your spine during daily life, and, importantly, address the fear and hypervigilance around movement that often develops after an episode of significant pain. That psychological component isn't imaginary or separate from the physical one. Persistent avoidance of movement is itself associated with poorer long-term outcomes.
This approach isn't identical for everyone. An older adult with age-related disc changes and lower bone density may progress more conservatively with lighter loads and closer monitoring.
A younger athlete aiming to return to sport will eventually need higher intensity, sport-specific loading, and rotational tolerance work, introduced carefully and later in the process. Someone with a sedentary job may need extra attention to hip mobility and posture endurance, since prolonged static sitting can aggravate symptoms independent of exercise. None of these differences change the underlying principle. They change the dose, the pace, and the specific exercises chosen. Surgery remains an appropriate option for a smaller subset of people, particularly those with progressive neurological weakness, significant loss of function, or symptoms that fail to improve despite a genuine trial of conservative care over several weeks to months. But for the majority of people with a herniated disc, current evidence supports a structured, progressive, exercise-based approach as the first line of treatment, not a last resort after rest has failed. So, the next time you feel that jolt bending down to pick something up, the instinct to freeze and stop moving entirely isn't the safest response your body has. Understanding what's actually happening inside that disc, respecting the stages of recovery, and gradually rebuilding strength and confidence in movement is what actually gets you back to picking up that bag of groceries without a second thought.